Right, very good evening, and it's my great pleasure and honor to have Professor Dr. Rajeev Chawla with us today. And Sir is a visiting professor at Jaipur National University, and he has been president of RSSDI, which is the largest research society of India, which is focused on research on diabetes. And today's discussion actually is totally focused on diabetes, and it's a very important complication, diabetic retinopathy. So, welcome to this webinar,
Good
sir.
evening. Good
Thank
evening, Dr. Deependra Singh. Thanks a lot for this opportunity and interaction. Good evening.
Thank you, sir. And we are celebrating our 8 years of telescreening, which is a fundus camera-based screening, which was installed at your place eight years back. So, tell me briefly about your experience.
I think it has been wonderful. In fact, if I say that our vision towards diabetic retinopathy, towards not only the screening, the management part, and the subsequent follow-ups has absolutely changed ever since we have gone on a fundal-based retina images, which we get beautifully uh, reported from your center. In fact, I remember we have been doing fundus as a routine screening almost since 2000. So if I put it like that, that since 2000 to 2014, I have been requesting many friends, those who are in practice of ophthalmology, to come to my center and do a regular screening for diabetic retinopathy. But unfortunately, that didn't work out. Second reason was that whenever we were screening our patient, we do a comprehensive screening for every type 2 diabetes, whosoever gets enrolled at our center as a first visit. Not only we do microalbuminuria, we look for their lipid profile, we look for their kidney function, liver function, thyroid. We do a baseline ECG, and we do peripheral neuropathy screening on bedside examination and by biotheometry and a vascular profiling also. So when we were not using fundal images, when we were not doing a teleophthalmoscopy at our center, our challenges were that we were telling our patient to go to a retina specialist, which not only was involving a visit to a ophthalmologist, other than the cost factor, the compliance was very, very poor, because most of the time patients are very reluctant.
Yes.
The moment we tell them first thing that you get a fundal examination for retina, their answer is that my vision is normal. Today only evening I had a similar patient, and I told them that until unless you screen for it, you will never come to know about it. So because they don't realize the importance of doing a retina examination till their vision is blurred.
Yeah.
So
Great point.
ever since we have started doing a screening every patient, and we repeat every 1 year, absolutely ethically, what is recommended by as a standard care by all guidelines, our own RSSDA guideline or American Diabetes Association guidelines. We screen every patient at the time of diagnosis. If it is type 2, if it is type 1, for the first time we screen after 5 years, because it is thought that type 1 will not develop diabetic retinopathy by 5 years, and subsequently every 1 year. So ever since 2014, we have started doing a regular teleophthalmoscopy at our center through a fundal camera. It compliance part has improved.
Yeah.
Earlier, we never realized that retinopathy we are missing so many times because patients are not compliant.
So, what was your first reaction when our team approached that you and said that we can actually do it with a fundus camera and do a reporting remotely by a internet-based system? So, what was your first reaction?
Honestly, I am not a very tech-savvy person. So 2014, when first time a representative approached from IQ, I was not very honestly very comfortable. In fact, my confidence in you as a retina specialist was there since beginning. So moment they told me that these reportings will be done by you on regular basis, so we were very keen to have that. But our reluctance was that we were not sure that we'll be able to pick up or do those images very, very effectively. That is one on our own part. We were not sure that we'll be able to create those fundal images very nicely. We'll be able to sort of click those images. So it just required that 3-4 sittings with your staff and our own reception staff and most of my own people, those who do our otherwise investigation, and they are our sports staff. They are able to do it now.
Yeah.
And second thing was we were little reluctant because we were not sure that the same images we will be able to reproduce and we'll be able to send it through iCloud or through the software, and it will still have the same quality, and whether we'll be able to get the right type of diagnosis on a cloud image. So those were the reluctance on our part in the beginning.
Excellent. And I think we were also very surprised by quality of images captured at your places. And even till date, we use your images to show people that this is what is being clicked at a diabetology clinic. At least do better than this. We our own eye clinics. So I think the adherence to the system and motivation of a physician to deliver best, I think, to their patients, really that drives this whole mechanism. What was the reaction of your patients when you asked them that we'll be clicking your retinal photograph and getting it screened? How did they take it?
I think that was also a challenge because prior to that, for almost 15 years, we were calling a ophthalmologist at our center maybe twice a week and all that. But moment we told them we are going to click this image here and we'll get it reported by a retina specialist, obviously the way we were reluctant. But moment we told them that we can get you these images, which you can have a second opinion, we are very sure of our retina people. And ever since we started sharing the images on iCloud, and the reporting was so consistent that now there is a huge confidence. I remember first year there was a little challenge. Patients were not accepting it. They thought that who is the specialist who is going to report on that? So we had to convince them that this will be reported by a retina specialist, and we can get you the images also. You can carry your images, and ever since then, I think now there is no challenge on that.
Great point, sir. And together now, I think in last 8 years, we have screened more than 6,000 patients.
Yeah.
So, and overall, I think there is a positivity rate of roughly 20%. So
18% precisely,
18%,
I remember. Yeah.
Yeah. So what is your take on this? Like, were you expecting this high percent, or like were your
honestly, Dr. Deependra Singh, it has been a true learning for my own self. If you ask me, one person who has benefited a lot, it is my own self, because we always knew that there is a varying degree of prevalence about diabetic retinopathy, pre-proliferative or NPDR and background. There have been studies talking about anything between 13 to 40%. Other day, I was discussing in a forum with Dr. V. Mohan, who has one of the largest data on diabetic retinopathy from this country. And moment I told him that one of our paper got published, and I shared with him Primary Care Diabetes, which is a very, very lead international journal, and that was a data of almost 3,300 patients, those who have been reported by your center. And there we found prevalence was, I think, 18.6%. He said that I'm very, very happy because we also have almost a similar data from southern part from our own diabetes center. So I think that is one thing which talks about that not only we are producing good images, as you really appreciated, we are getting very consistent and very homogeneous type of reporting. So now, since 8 years, we have seen that consistent the prevalence of diabetic retinopathy in our center, as you very rightly said, is close to 18 to 20%. And important thing is that we are able to pick up those patients at a very, very early stage, something like as early as background diabetic retinopathy or non-proliferative diabetic retinopathy. At that stage, I think the best thing is to have a glycemic control, to give them statin, to have good blood pressure control. So we also get sensitized that this patient needs much more emphasis on glycemic control and other things so as to check the progression of diabetic retinopathy. So that way, it has helped us a lot, not only in building our own data, but also in getting compliance from the patient. And I'm sure these patients whom we have screened over 8, 9 years definitely have benefited in terms of checking the progression of diabetic retinopathy.
Excellent point, sir. I think this actually answers my next question, that what impact this screening mechanism must have done to your patients. And this is very interesting point you brought out, that not only the retinopathy which requires treatment or referral, even the milder retinopathy detection at a diabetology clinic can have huge impact in overall, management of diabetes and journey of a diabetic patient. And probably we need to explore this in further studies. Early diagnosis, what impact it can bring to our patients. Besides, we are always in telescreening program. We are always focused on retinopathy, which requires referral or which is sight threatening diabetic retinopathy. But this is very interesting point you brought. Uh, Now, one thing which I think can, create a hurdle between a hurdle for a effective telescreening program is screening test in general. They have a lesser sensitivity and even lesser specificity than conventional examination techniques. So, what is your take on this?
I think if I go back and dig my own data, which you also have, because you have been giving us all those inputs along with images and wonderful, very consistent reporting. So I don't think we have really missed anything.
Right.
Contrary to that, if I say that if I diagnose a patient with background diabetic retinopathy today or non-proliferative diabetic retinopathy, we we immediately get sensitized for a tight glycemic control. Second important thing is that then we can reinforce that down the line, when is the next time that you must see a retina specialist. So normally what happens is that, as I told you in the beginning, patient many a time may not have any blurring of vision, at least in background diabetic retinopathy, or maybe even non-proliferative early diabetic retinopathy. So they may not be very taking it very seriously. But moment we tell them that down the line we will follow these patients not only with tight glycemic control, with a adequate dose of statin, with good hypertension control, we follow them for a follow-up visit so that we know that they are not progressing. That is one. And anytime we find that they are little unstable or they immediately require, and good thing is you have always been telling us very ethically that this patient needs a referral maybe in 4 weeks time or 8 weeks, or maybe a subsequent follow-up with us only 6 months, and then repeat a fundal examination, so that many times we may be able to avoid their unnecessary visit. That is one. And second important thing is, whenever warranted, we know that this patient must go back to a retina specialist. So both way it serves a purpose to the patient. To us, it gives a lot of insight. To patient, the advantage is that we don't unnecessarily send them for a repeat retina examination to a center, because we know these patients are having a background diabetic retinopathy, and screening maybe once in year may be good enough. So that avoids their unnecessary visit. And once we find someone who already has maybe more than non-proliferative diabetic retinopathy, we tell them that this is the time you must go to a retina specialist. So that way, lot many life-threatening, vision-threatening patients can be handled at a much early stage. So both way it serves best interest of the patient.
Excellent point, sir. Uh, you have recently published your results and a study where you correlated between microalbuminuria and diabetic retinopathy, and it was published in a very reputed journal, Primary Care Diabetes. So, tell us how telescreening help you, get this data, and what is the news for coming from this Indian
Yeah,
study?
this is what I said. See, whenever we are doing a comprehensive under one roof diabetes checkup, or we offer that under one roof, we are providing you everything what is important in setting of type 2 diabetes. until unless we do a fundal imaging and get a retina opinion, it becomes incomplete. These days, because whenever we have to present a data or a publish a data, you know my interest, I keep doing regular publication. So to us, it is very important to have our own bank, because if I'm talking about modifiable risk factors, if I'm trying to correlate microalbuminuria with any other microangiopathy, the way we did in our paper, until unless we have an information on retina or fundal images, we'll not be able to publish any data. Also, it will be an incomplete data until unless we have at least information on neuropathy, we have information on retina, we have information on lipids, and we have information on albuminuria. And that is what we did in this almost 3,300 patients, those who had diabetic retinopathy. We looked into their microalbuminuria, we looked into their lipid profile, we looked into their smoking habits, we looked into their blood pressure level, and then we tried to correlate that if you have diabetic retinopathy, maybe when it is early background diabetic retinopathy, it has a very strong link with other modifiable risk factors, which are like microalbuminuria. And this brings to me a very good quote, which I give it to all patients, that looking into retina or eye is a window of opportunity to avoid all other major complications in setting of type 2 diabetes. So if we are able to look into this window, if we are able to do simply a fundal examination, I can tell you that this patient has another modifiable thing. Maybe he's not going to have a disaster because of coronary artery disease, because we are able to relate their albuminuria, we are able to relate their micro versus macro angiopathy. One of our publication, I must quote here, this is in Indian Journal of Endocrinology Metabolism 2016. Again, there we said that micro and macro are going hand to hand. Gone are the days when we were saying that macroalbuminuria or macro complications start much earlier, micro only start after the onset of the disease. Although that is still true, that is still a dictum. By the time you have diabetic retinopathy, you must have albuminuria. That means these are going hand in hand. But we said it must be viewed as a continuum, so that if patient has one complication, simply microangiopathy like peripheral neuropathy or microalbuminuria or fundal changes of even background diabetic retinopathy, this must sensitize to all treating physician that you look for other things also, because everything is going hand in hand. So if you have microangiopathy, you must look for macroangiopathy. If you have macroangiopathy, you look for other risk factors which you can modify so as to prevent so many other fatal complications coming as a result of type 2 diabetes.
Excellent points. I think so. What we get here is that even research is incomplete without information
Without
of
getting complete information.
retinopathy, and I think very good learning point for all the colleagues. So, what would be your message to physician colleagues who are still slow in adapting this approach for DR screening?
I think before I make a recommendation here, it is again important to mention another data which we publish in International Journal of Diabetes in Developing Countries. Again, this was a data of almost 3,600 patients, where all the reporting was done by your center. We said that doing a nurse operated teleophthalmoscopy comes out to be very, very cost effective tool in averting maybe tomorrow a blindness or much more serious conditions, because it costs nothing. Moment you have a fundal camera which you can own or you can have on license basis, and you send your images, you get it reported from a retina specialist, it hardly costs anything. See, if you refer a patient to an ophthalmologist, obviously it is going to cost at least 1,200 to 1,500. Not only that, it is going to take a physical visit to that retina center, and patient is obviously going to travel till then and going to spend 2, 3, 4 hours. So if you simply do a teleophthalmoscopy, which can be done by any trained nurse in your center, anyone can be trained on that within 7 days time, the way we started, it comes out to be very, very cheap. There we said we did a cost effective analysis also. We said it hardly, it that time dollar was 60 rupees. So I said it hardly costs you $6, $7 to get one image and to get it reported, rather than referring a patient to a retina center and then spending 1,500 rupees. So not only you are saving on time of the patient, you are saving a physical visit, and you're also saving huge amount of money which patient will spend otherwise doing a physical examination. So I think I must say all physicians or diabetologists, those who are involved into the practice of diabetes, they must have today a fundal camera. Teleophthalmoscopy is a golden tool these days. We publish another data here. In COVID times, it came out to be so handy. Otherwise, those 2 years when patients were not able to go to any other clinics, if they were visiting even once at our center in once year, we said that continuum of care can be maintained if patient visits your center maybe once in a year and does 2 to 3 teleconsultation. So there also we said that that entire continuum of investigation and follow of the patient can be maintained even in COVID times, and that is true for especially those patients, those who are coming from two distant places. So patient just needs to come for one single visit to our center where we do a comprehensive package. We do fundal examination and entire investigation, and patient then can follow you for another 1 year by 1 or 2 televisits. So all those peripheral centers where the services of a retina specialist are not available, 2 tier, 3 tier cities, Delhi, it may be still possible. They must have a fundal camera because they may send images from distant places and they can have best opinions from retina specialists like you, and they can be much wiser before disposing of that patient, that how to do and how to proceed. So I think in a practice of type 2 diabetes or type 1 diabetes at any clinic, whether it is in Delhi or at 2 tier or 3 tier cities, these days a fundal camera is very, very handy. It's sort of gold standard. These international recommendation today on telescreening are not to send a patient to a retina specialist or screening. They should only be referred if they require further intervention. If they are simply background diabetic retinopathy, you need only glycemic control and blood pressure control and cessation of smoking to check progression, which can be simply done by a fundal camera.
Excellent point, sir. What kind of guidelines and I think support from government and societies are we expecting, to promote this telescreening at community level and other healthcare facilities beyond diabetology clinics? Because you are part of a lot of bodies which is involved in forming policies. So if you can update us on that.
Yeah, unfortunately, till now we don't have guidelines from Government of India or Ministry of Health on telescreening, but our own Research Society for Study of Diabetes in India guideline 2020 edition, which I was the lead author, and I convened that entire recommendation. And 22 it again has been recently published in October itself. There we said that every patient these days should be screened for diabetic retinopathy, as I said in the beginning, right at the time of diagnosis, first and every 1 year. And type 1 must be screened first time after 5 years and subsequently every 1 year. And that is only possible if you have a fundal camera at your own center. So I think this is absolutely now adopted and recommended by all organizations, whether you talk about international organization or Indian guidelines. RSSD ASI is adopted by Government of India as Indian guidelines. So there it is clearly mentioned that if there is only background diabetic retinopathy, a screening visit followed by 1 year follow may be good enough. If there is something like pre-proliferative or proliferative diabetic retinopathy or maculopathy, maybe a follow-up every 3 to 6 months is very, very important with a retina specialist. So that information you can only collate moment you have screened your patient with a fundal camera. And then obviously prognosis wise also you're much better. You can tell your patient that now you must have a good glycemic control, and you can follow those patients every 3 to 6 months to check the progression of the disease.
Great points. I think thank you, sir, for sparing your time. And any closing remark on this approach, and maybe some good anecdote, like patient experience, which you remember that maybe I think in last 8 years.
I think as I said, I remember many a time. Another thing which I just forgot to mention: all females, those who are in reproductive age, we screen them for presence of diabetic retinopathy, because we know moment they are going to conceive, there's going to be a progression of diabetic retinopathy. Unfortunately, it is a known fact. There is huge evidence that moment if you have background diabetic retinopathy, that may progress to non-proliferative. If you already have non-proliferative diabetic retinopathy, that may further worsen during pregnancy. So all females, those who are in reproductive age, before they conceive, a fundal examination is absolutely must. So I think now it is high time that we must start screening our all patient, not only for retina, for presence of microalbuminuria, for presence of dyslipidemia, for presence of peripheral neuropathy, and doing a background, a baseline ECG to rule out a coronary artery disease. Because if you have not looked into that, you will never be sensitized, and you will never be able to check the progression of micro as well as macro SL complication in type 2 diabetes. So all these things under one roof are so handy. These are so competitively priced now. So I think every patient should not be, no patient should be deprived of the benefit of screening for baseline microangiopathy and macroangiopathy moment patient is with you for a diabetes consultation.
Excellent, sir. Thank you. Thanks so much. And it was pleasure
Thank you.
interacting with you. I know this topic is very close to your heart, and we can have very long, extended discussions as usual. But I'm sure it will be a great learning for all our listeners and audience. And the whole idea of this video was to create awareness and sensitizing program, mainly for our colleagues who are involved in care for diabetes.
Still reluctant. People are, I don't know why people are still reluctant. I think I'll be extremely happy if this discussion and interaction of ours can serve a purpose in terms of sensitization of physicians involved in practice of diabetes, that they must screen for all micro and macro angiopathy right at the time of diagnosis and every 1 year subsequently.
Great, sir. Excellent. Thank you so much. And
Thank you. Thank you.
thank you.
Thank you, Dr. Deependra.
Thank you.
Wonderful talking to you. Thank you.